plasma glucose of greater than or equal to 126 milligram per DL, which is equivalent to 7 millimoles per liter, an OGTT of greater than or equal to 200 milligram per DL, and a glycated hemoglobin of greater than or equal to 6.5% or 48 millimole per mole. Now, the burden of the disease is that 39 million Nigerians presently suffer from diabetes. So you are going to have a greater number of your patients presenting with features of diabetes in one way or the other. Some even will be presenting now, their first time to discover, when they come for surgery, to discover that they have diabetes. Approximately 5% of the adult population between the ages of 20 and 79 suffer from diabetes. Now, there's an increasing number of adolescents and young people, young adults, who are suffering from diabetes as a result of obesity, sedentary lifestyle, and some other lifestyle and environmental conditions. Now, the WHO and American Diabetes Association have classified diabetes into the following categories. Type 1, which used to be known as the insulin-dependent diabetes mellitus, is immune mediated as a result of autoimmune disease. And in this type of diabetes, you have absolute deficiency or near absolute deficiency in insulin secretion, and there's reduced or absent absolute pancreatic cell dysfunction. Sorry. Now, in type 2 diabetes, which used to be known as non-insulin dependent diabetes, there's insulin resistance and relative deficiency in insulin secretion. Most of the patients you'll be seeing would probably be type 2. And most of these patients would also be presenting to you for the first time at the time they come for surgery. Now, there's a wide range of different specific types that are called secondary diabetes that we'll be talking about as we go on. Now, the other type is gestational diabetes that is discovered in the 3rd trimester of life and is associated with the production of delivery of bigger babies. And many of these patients also will be, they have preclinical diabetic cardiomyopathy. Some of them have autonomic dysfunction. And some of these patients actually would have, will come in as with a greater risk of instrumental delivery and conversion to CS. So many of these patients develop type 2 later in life. 30 to 50% of them develop type 2 diabetes later in life within 10 years. The other classification here are the pre-diabetics that are insulin, that are impaired glucose tolerance, that have impaired glucose tolerance, and they have a fasting plasma glucose of less than 126 milligram per DL, or an OGTT of 140 milligram per DL to 200 milligram per DL. Also, we have those that have impaired fasting glucose with the definitions as outlined. Now, this is just a classification of the ones I talked about, secondary diabetes mellitus, that do not result from, that are not, so to speak, the type 1. They result from other secondary causes of insulin deficiency. And these include those that come with pancreatic diseases like trauma, pancreatic surgery, that have pancreatic cancer. They will present sometimes with features of diabetes. We also have those that have endocrinopathies like Cushing's syndrome, acromegaly, pheochromocytoma. Obviously, there's an increased production of counter-regulatory hormones that are anti-insulin. Then we have drugs, chemicals, infections, genetic syndromes, and even post-transplant patients might present with features such as that will give you features of diabetes. Now, talking about the pathophysiology, basically the cause of this diabetes or hyperglycemia is when we go back to the physiology, we know that insulin causes increase in glucose uptake, glycogen storage and protein synthesis, as well as amino acid transport and lipogenesis. So when there's a defect in the action of insulin, whether by resistance, increased resistance to it from the target organs, or as a result of deficiency of its secretion, we now have abnormal carbohydrate, fat, and protein metabolism. So there's a resultant gluconeogenesis, proteolysis, lipolysis, and decreased amino acid transport, which might also eventually end in ketogenesis. And of course, the counter-regulatory hormones act as they are anti-insulin and also cause the effects that we have discussed. Now, the sustained diabetes can present with acute complications or chronic complications. The acute complications include diabetic ketoacidosis, hyperosmolar hyperglycemic syndromes, and the chronic complications can result from sustained hyperglycemia, causing accumulation of sorbitol in peripheral sensory neurons, axonal degeneration and segmental demyelination that may result in neuropathy. The neuropathy may be polyneuropathy, proximal neuropathy, mononeuropathy, or autonomic neuropathy. Now, microvascular disease will result in the features that we see of neuropathy, nephropathy, and retinopathy. If the arteries of the heart and the brain are affected, macrovascular disease, we can have coronary artery disease, peripheral artery disease, or cerebrovascular disease. The glycosylation of soft tissues can also result in slip joints. Now, this is just a diagram basically showing a summary of everything, the pathogenesis. Now, there's an interplay of the genetic causes and, of course, increasing studies have shown increasing causes of that are called idiopathic. And of course, in type 2, that is mainly as a result of the interplay of the environmental factors like viruses, microbiome, lack of physical activity, dietary factors, obesity, dyslipidemia, all these things can now result in inflammatory response and or autoimmunity that will cause beta cell dysfunction, and even metabolic stress can also cause beta cell dysfunction. All these act on the pancreas and then result in hyperglycemia that we now see as type 1 or type 2. And of course, all the hyperglycemia can result in all these chronic complications that we have spoken about. Now, when we have a diabetic patient and you want to, you're considering, they've sent you a consult that this patient is going for surgery. There are certain things when you're going to go for a preoperative assessment that should cross your mind. And this include when there's untreated or poorly controlled diabetes, the patients are prone to osmotic diuresis, so they can have dehydration. And of course, these patients might be presenting to you with acute complications of diabetic ketoacidosis, hyperosmolar hyperglycemic syndromes that will require resuscitation. The patients intraoperatively are prone to labile blood pressure fluctuations, and you would need to ensure that this is their preoperative state is properly optimized. These patients that are prone to labile perioperative blood pressure will require close monitoring intraoperatively. The patients, of course, diabetic patients have various stages of nephropathy. And as a result of this, there's decreased renal excretion of anesthetic drugs and prolongation of the actions or overdose, resulting in overdose of anesthetic drugs. Some patients might present to you at end-stage renal disease requiring different kinds of surgery, and fluid restrictions will be required in this class of patients. And autonomic neuropathy is very important that we take note of this, because this can result in delayed gastric emptying, predisposing the patients to aspiration, and they can also develop postural hypotension. This is important for especially the gestational diabetics, perioperative hypotension, hypothermia, and abnormal cardiac reflexes, and silent myocardial ischemia. Now, the patients can at risk of difficult laryngoscopy and endotracheal intubation. So you would need to get your difficult airway trolley ready and available, because the temporomandibular joints and the atlanto-occipital joints or the cervical spines might have experienced some glycosylation that would make mobility a bit difficult. Hypoglycemia and hyperglycemic crisis or cerebrovascular insufficiency can result in altered sensorium. So you want to avoid all this or minimize the risk of this during surgery. Also, cardiac arrest, or patients that have had cardiac arrest, cerebral ischemia with diabetes, present with worse prognosis. Then there's immune deregulation as a result of the release of some metabolic toxins that can affect the immune system and result in increased risk of infections in these patients. Stress response to illness, surgery, or anesthesia increases the release of cardioregulatory hormones, which also result in altered insulin requirements. So there's an increased requirement of insulin. The patients are more prone to hypoglycemic, and this is known, of course, as a stress hyperglycemia, and there's increased cardiovascular complications. Now, when we go for our preoperative assessment, the history is very, very important. Of course, when you are going for your preoperative assessment, there's the history, physical exam, and investigations that you order as a result of your findings. Taking history, it is very important to understand from your history. Many patients actually can tell you, especially the educated patients or those ones that have been treating, that have had long durations of diabetes, will be able to tell you the type, or from your history, you know the type from the type of time of onset, how long they've been diagnosed as being diabetic, and the details of their treatment. This is very important because you are going to require this in modulating modulating your treatment and optimizing your patient, so that the risk during the surgery is reduced to the barest minimum. Now, the nature, duration, and compliance to treatment. For some patients, some type 2 patients are actually maintained on diet, especially those that have been very careful. Maybe they had impaired glucose tolerance, or they had GDM, and they've been maintained on diet successfully. Some patients might be on oral hypoglycemic agents or non-insulin injectables. Some might also be on insulin. So that gives you an idea of exactly, you want to know how long they've been on it. Have they been compliant to treatment? What has been their blood sugar control in the course of the illness? Some patients will be able to give you figures even of their glycated hemoglobin concentrations. The glycated hemoglobin actually gives you an idea of the control over the last 3 months. It is not one to make you decide, are you going to take in the patient or not? The perioperative blood glucose gives you a better idea of perioperative complications that can arise. Studies have shown that the perioperative glycated hemoglobin concentration does not really have a bearing on the outcome or surgical outcome. So you don't want to cancel a case, especially an urgent case, because the glycated hemoglobin is not within normal limits. Now, having said that, the history and severity of target organ involvement and even other comorbidities are very important, as well as the treatment that has been given this patient. This prompts you to know how bad and or how well the control has been. And also the other issues you need to deal with intraoperatively. Then the type of surgery is important. If this patient is coming for a minor surgery that would not be of long duration, you might want to be more less worried about the perioperative complications. And it also sort of modulates how you're going to control the perioperative glucose therapy. Now, if the patient comes in who is well controlled on diet and is coming for a minor surgery, you might want to not even start a perioperative insulin therapy, because it's not, you put the patient in the morning and you can go ahead with surgery and it's done in a few minutes and the patient can go back to whatever their treatment was preoperatively. But if it's a major surgery, it is important that you plan the perioperative glucose control detailed. A detailed plan must be taken and planned out. Now, susceptibility to hypoglycemia and hypoglycemic awareness, the history of this is important. Some patients will be able to tell you that I easily get hypoglycemic, or when I'm hungry, I'm not able to tell. This is a pointer that you might have the same complications in the perioperative period. Now, of course, the history that you're going to be taking, the detailed history of the various systems would include history of hypertension, coronary artery disease, even history of cerebrovascular disease, peripheral artery vascular disease, even cardiomyopathy. All this has to be sought for while you go and do a preoperative assessment for this patient. Also, in your examination, all this should be noted and the signs should be sought out for. The renal history, when you're taking your history, the history of diabetic nephropathy is very important. The patient will be able to give you history suggestive of diabetic nephropathy. You might want to ask about if they've had dialysis, the type of treatment they've had for the diabetic nephropathy. Now, in the nervous system, you might want to, you want to also ask, because 30 to 40% of these patients have autonomic neuropathy. So you want to take history to ensure that, to discover if this is one of the complications that the patient has. In the eyes, they have cataract or diabetic retinopathy. And then, of course, diabetic patients are prone to chest infections, and especially the obese and smokers. Now, physical exam. As we have said, our physical exam should be detailed and tailored to the complications that we have at the back of our minds. Then other comorbidities and complications. So in the general exam, you might find a patient that has lost tremendous weight, or even an obese patient. There might be some abdominal fat. Usually the type 2 patients are obese, or they might have abdominal fat, truncal obesity. You might see some syndromic fasces. There might be ulcers in the leg ulcers, or there might be edema if this patient has, or there might be if this patient has cardiovascular disease, and they might be lethargic. If they are presenting with acute complications, then some of them, the autonomic neuropathy patients might come with tachy or bradycardia, and they might have postural hypertension. Then in the airway, it's important to examine the airway for neck mobility and the prayer sign. Now, the prayer sign talks about being able to bring the palmar surfaces of the 2 fingers together, doing like the prayer sign. When you have the patient that cannot oppose the 2 fingers together, they are indicative of the fact that you might have a difficult intubation. Now, the investigations that are very important in this patient, of course, are the fasting plasma glucose. You want to know what you're starting with. This will enable you to know if you need what the adjustments need to be done perioperatively, the OGTT, plasma glucose, and of course the glycated hemoglobin. Now, a glycated hemoglobin of 4 to 6.5 is normal. If you have it less than 7, it's good, it's tolerable, and within what you can use that is within acceptable limits. But when it's beyond 10%, then it shows you that there's inadequate control, and you might have increased risk of complications perioperative, or it just indicates to you that the control has been bad over the last 3 months. But when you have it over 12, the patient is at the verge of ketoacidosis. Then you want to also do a full blood count that will tell you if the white cell is important, and you want to know if there's any evidence of infection. Of course, we all know sepsis, you can have it either very high or very low. You have to keep that at the back of your mind. And then you also want to know the PCV. Some of them have low PCV as a result of the effects of the infection as well. Some of the patients that have had repeated dressings also might have lost quite some of blood through that process. Then the electrolytes and urea creatinine, they are very important. These patients might come in with hypo or hyperkalemia. They might have hyponatremia. They might have high urea and creatinine levels showing that there's a renal compromise. They can come with hypomagnesemia or hypophosphatemia. And of course, the ketones in the blood are very important. Any value above 3 millimole per liter is very significant and suggestive of decompensation. Blood urinary nitrogen to value is very important. Any value above 20 is indicative of the fact that there's some compromise. And if it's over 100 milligram per deciliter, it's suggestive of rapid decompensation in that patient. Then the osmolality is important because it helps us to know this is increased in DKA and more so in hyperosmolar hyperglycemic syndrome. Then the GFR will give you an idea of the stage of renal disease. So you are able to adjust your anesthesia appropriately. Of course, we can do a blood culture. It helps us to know what antibiotics, if the patient has infection, that the antibiotics that are relevant to the patient and effective. Then the urinalysis, if we're not able to do some of these things and we have an emergency in our hands, a urinalysis is very important because if you find glucose, by the time you are finding glucose, protein or ketones plus, if they're increased or plus in the urine, they show you an indication of what is happening as well in the blood. Then an arterial, depending on the acute nature of the disease or the condition of the patient, an arterial blood gas is very important, especially in patients that have DKA or are coming in a coma or are very ill with sepsis. An arterial blood gas would be very, very helpful. It will show you acidosis, the bicarbonate, and the lactate would be increased. Now, also, radiology is important. You might want to do a chest x-ray. It might indicate some mnemonic changes in the chest. The heart might be enlarged. You might have pulmonary edema in patients that have been having a renal failure and their fluid therapy has not been adequate, or even as a complication of the renal failure. And then ECG is very important because these patients are prone to MIs and coronary artery disease. You will be able to know if it's a non-STEMI or a STEMI. Then the cardiac stress test too is important in patients that have history of cardiac disease. Now, what are the objectives of our preoperative optimization? The main objective is to reduce the risk of morbidity and mortality in the perioperative period. So you are not so, you want to look at glycemic control preoperatively. You want to know what the patient has been doing at home during the course of the acute illness or chronic illness. You want to know what the patient is presenting to you at the point of assessment. All these are going to be taken into consideration. You want to ensure that this is controlled as much as lies within your power before the patient is put under anesthesia. Now, it's important to note that if the patient presents for emergent or urgent surgery, you might not be able to achieve tight glycemic control. But if the surgery is an urgent, an emergent one, there's some levels that are allowed for the patient up to 150, up to 250, 200 milligram per DL of sugar will be allowed while there's ongoing treatment so that we can allow the surgery to be done. Now, you need to plan perioperative management of your perioperative glycemic control. And your aim is that the sugar control should be between 120 to 180 gram per DL, which is equivalent to 6 to 10 millimole per liter. Values of 4 to 12 are acceptable. And now studies have also shown that it's not the pre-op glycemic control sometimes that is indicated by glycated hemoglobin values that are most important, but the perioperative glycemic control. So you don't want to be hung up on the glycated values or pre-operative control. The perioperative control is what is most important. Now, it is important also to treat comorbidities as especially for patients that are coming in for elective surgery and you have time. It will be good to ensure that the comorbidities are within control and even other life-threatening conditions. Now, if the patient comes in with DKA, you don't want to rush him. You want to try and do something about that. And even other things like hypokalemia, hypoglycemia, and other electrolyte imbalances or dehydration need to be corrected before the patient is put under anesthesia. Now, like I've said, your preoperative optimization lies a lot on whether it's elective or emergency or whether it's a major or minor surgery. For major surgeries, it can, the type of surgery can range from a patient coming in for cardiac or thoracic surgery to a patient coming in for an ingrowing kidney, a very minor surgery. So whatever you're going to be doing has to put all of this into consideration. Also, your intraoperative monitoring needs to be planned in the preoperative period and preparation. Now, it's also good to do a risk assessment and note it and discuss with the relatives. The relatives and even the patients are very important in ensuring that there's a smooth perioperative period. As well as it's important to note that success of your optimization and even preparation of patients depend a lot on your assessment, your risk assessment, and multidisciplinary approach. The endocrinologists, the nephrologists, and other disciplines have to be carried along in the management of this patient. Also, you need to plan for the post-op care. Is this patient going to require a high dependency unit or ICU care? Or is this patient good to go to just be discharged home from the PACU? All this need to be taken into consideration, discussed with the patient and the relatives and other professionals involved in the management of this patient. Now, we need preoperatively to correct any hypoglycemia that is above 200 milligram per DL. You want to achieve a control that is less than that. You want to correct fluid and electrolyte imbalances and ketosis if it is there, if it's seen. Renal failure the dialysis should be done a day before the surgery. Then you want to consider, do we discontinue the oral hypoglycemic agents? Do we, and the non-insulin injectables, do we discontinue, reduce or discontinue insulin? And all these decisions will be taken with the background knowledge of the duration of actions of these various modalities of treatment. Because you want to know, are they long-acting or short-acting or intermediate-acting agents? Also, is this patient using a subcutaneous insulin pump that can be continued and used intraoperatively? You want to know, and you also want to acquaint yourself with the various modalities of treatment so that you can tailor your management intraoperatively and even preoperatively accordingly. Then you want to commence soluble or intravenous insulin for patients that are going in. You want to consider this in long duration surgeries, major surgeries, or in patients that are critically ill. For all patients that are critically ill, it is essential that we commence soluble insulin, because the adjustment of this dose of insulin is easier, and the duration of action is within 10 to 15 minutes, that it can easily be readjusted to suit the glucose monitoring that we're doing intraoperatively and the values that are gotten intraoperatively. Now, you want to see if you want to discontinue sodium glucose cotransport 2 inhibitors like canagliflozin. This is talking about our oral hypoglycemic agents now. Generally, oral hypoglycemic agents are said to be discontinued. In the past, they said you discontinue 24 hours to 72 hours prior to surgery. But now the teaching is that you actually only stop them the day of the surgery, meaning the morning of the surgery, except, of course, for agents like canagliflozin that have that you need to stop 24 hours prior to surgery because they can cause euglycemic ketoacidosis, or chlorpropamide that is not even in use in many institutions or even abroad anymore, that you need to discontinue 3 days prior to the surgery. Now, generally, this is just a table showing perioperative management of oral diabetic medication. For acabus, when we look at this table, we can see that for most drugs, you continue them till the morning. Now, you want to consider, is your patient going in for surgery in the morning, or is the patient going in for surgery in the evening? That's after 12 noon. You want to know, is this patient, for most patients, you can actually omit their morning dose alone. For most patients, for most of the drugs, except for metformin and pioglitazone, that you can take as normal. But caution has to be exercised when the patient is on metformin, because in procedures requiring contrast media or patients that have a GFR less than 50, you want to omit or discontinue metformin. Now, also, when we look at this table, we can generally see that you just omit in the morning if it's a morning surgery, or you omit morning dose even if it's an evening surgery. Now, for the glucagon-like peptide 1 analogs here, like liraglutide, are the injectable non-insulin agents. So that also can be omitted on the day of surgery. For acabus, you can actually give the morning dose if the patient is going to take a meal in the morning. Also for meglitidenide. Now, considering the insulin therapy, the subcutaneous insulin therapy, for patients that are on insulin therapy, usually they are given a basal subcutaneous insulin therapy. And some of them that actually have insulin pumps, subcutaneous insulin pumps, have this pumps preloaded and devices that can be used to give them, that can have buttons that can be pressed to deliver extra doses of insulin as required. Now, the basal insulin therapy, if the patient has a basal insulin therapy that is long acting, you want to reduce the dose by 20 to 25%. If it's a morning, if it's in the morning, if the surgery is in the morning, you reduce the dose the evening prior to that morning surgery by 20 to 25%. Now, if the surgery is in the evening, so you would want to reduce not just the evening before, but also the morning of the surgery, you reduce the long acting by 20 to 25%. Now, if the patient is having high doses that are greater than 80 units per day, or in elderly patients, or patients that have renal or hepatic impairment, or a risk of hypoglycemia, when they tell you that they've had hypoglycemic crisis before, you want to reduce their doses the night before by 50 to 75%. Now, ultra long acting subcutaneous insulin, you need to reduce this three days prior to the commencement of the surgery. And in this kind of patients, you would require the help of the endocrinologist to ensure that the patient's glycemic control in that period is adequately monitored and attended to. Now, intermediate acting agents, you want to use the usual dose the night before, or 50%, then you also use 50% of it in the morning of the surgery. Now, for intermediate acting subcutaneous insulin, it is not, studies have shown that it is not very safe in the perioperative period. So you might want to discontinue them and then just commence your, if it's a major surgery, just commence your intravenous insulin regimen. Now, for premixed formulations, 50%, you can use 50% of the dose and then commence dextrose, so that because these patients, you need to even consider discontinuing them because these patients are prone to hypoglycemia. Now, for the subcutaneous insulin pumps, patients that are getting their subcutaneous insulin through insulin pumps, like I said, they have buttons that you can press to discharge nutritional. Now, the nutritional insulin therapy talks about when the patient is eating. Now, for fasted patients, this must be discontinued as they are not eating. And also, in these pumps, you can also deliver correctional insulin therapy. So for patients going in for surgery, you want to continue the basal subcutaneous insulin, and then prior to your surgery, you want to deliver correctional values if they are indicated. Now, if you come to the point where you now have to have a major surgery, or the patient has critical illness, all this would be overturned by the use of continuous intravenous insulin or any other continuous intravenous insulin therapy to ensure that the control is adequate and adjustments are done quickly. We have two continuous intravenous insulin regimens. The first one in this table is the JK, also known as Albati infusions, based on 5% glucose. Now, 10% glucose can also be used. The one that we are all usually familiar with is the 10-10-10. That's 10% glucose with 10 to 15 international units of insulin and 10 millimoles of potassium chloride. But 10% glucose is not always readily available, except, of course, you have planned previously for it. So as a result of that, we have also been given this table to also use the 5% regimen. So for this patient, you want to look at, with the blood glucose, when you want to use this regimen, you will use your 5% dextrosaline, or 10%, the 500 ml bag of 5% dextrosaline, or 500 bag of 10% glucose. And when the blood glucose is less than 4, you want to use 5 international units and add it to that. And if the potassium is less than 3, you can add 20 millimoles of KTL to that bag. Also, if you can adjust your therapy accordingly. If it's 4 to 6 and the potassium is 3 to 5, you can reduce your potassium. Yes, please.
You have 2 minutes to go. 2 more minutes, please.
Okay, I'm almost done. So you can adjust your potassium accordingly. We can go through that as we go. Now, for the variable rate intravenous also called the sliding scale. You want, basically what you're going to do here is your fluid, you can use this table to regulate your fluid. So what we actually use is the first choice fluid for this is 0.45% normal saline plus 5% glucose. This same thing as dextrosaline and half strength normal saline. And it's going to run at 120 mils per hour. So your insulin is added to that fluid. You can also make your insulin infusion 1 unit per mil, so that you are able to use this because you will make up your feed to ensure that it's giving you 1 unit per hour. Now, in patients that have a higher glucose ab initio, you have to use a higher value here. For patients that have a baseline insulin therapy, you want to omit it or treat them as hypoglycemics. So you adjust this accordingly. Now, if you know that your blood glucose level is higher than 20, you would want to check and include the diabetic team of the hospital, the endocrinologist, or check if your fluid is going appropriately. Now, for DKA, we usually find this, some patients might present with DKA or HHS, and you want to treat all of this. So these patients present with ketosis and acidosis, a pH less than 7.3, and you want to treat them by giving them saline, 1 liter start at 1 hour, 2 hours, 4 hours, and 6 hours. And then when you have treated, what is of utmost interest is the dehydration. You want to treat that dehydration, and then insulin, you want to start insulin when if the sugar is above 20 millimoles per liter. You want to start a sliding scale to ensure that the insulin is brought, the sugar is controlled. Then when the sugar comes to below 50 millimoles per liter, you then want to start dextrose with it. Now, it's important to note in all our therapies that insulin must not be given separately. Insulin and the glucose must be given in both regimens within the same cannula, so that there's no inadvertent infusion of insulin without. And of course, in our BATI, you monitor it's at a rate of 100 mils per minute per hour, and in the sliding scale is 120 mils per hour, and you monitor their glucose by 1 to 2 hours, between 1 to 2 hours intervals. I think I'll just go ahead since I have very little time. Now, an approximate guide to insulin infusion is the plasma glucose over 5 when you are giving the variable rate intravenous insulin infusion. Of course, for HONC, what is important, it is usually happens in type 2, and some patients might be presenting first in coma or in osmolar hyperglycemic syndrome. So there's marked dehydration, and there's no ketosis. So it's important to note that the osmolality is very high, and the sugar is actually higher than what you have in DKA. So it's important that you give half the rate of the fluids that you give in DKA, and full heparin anticoagulation, and you try to lower the sugar at a rate that is not too high, so that there's no cerebral swelling. Now, also, patients can present with hypoglycemia or hypoglycemic coma, and this is plasma glucose that is less than 4 millimoles per liter. You want to treat this. It might be precipitated. DKA, HHS, and hypoglycemia can all be precipitated by infection, liver failure, alcohol, or even fasting. So you want to give the patient sugar as indicated here, or either intravenously or glucagon, but you don't use glucagon in patients that are drunk. And then you can also give orally if the patient is still awake and alert. Now, I think I've discussed it, for elective surgery, you want to put the patient first. You want to do a plasma glucose 1 hour before surgery. You want, if it's minimally invasive and it's type 1, you might omit the subcutaneous insulin and then do the surgery, and then a light, if it's an afternoon meal, you want to do a light meal and a normal dose. Then if it's type 2 and diet control, there's no special treatment. If the patient is on oral hypoglycemics, you would monitor and manage as we have previously discussed. Now, if it's a major surgery and it's invasive, there's more stress. There's release of counter-regulatory hormones. So you want to admit these patients early, have a proper endo review, and do a tighter control. Then you want to check the plasma glucose and potassium and manage this accordingly. You also want to plan your insulin or oral hypoglycemics on the day of surgery. You want to commence your preferred intravenous insulin regimen. And it's good to note that the reason why a lot of us prefer Alberti is because it doesn't require volumetry pumps or an anti-reflux valve for the glucose line. So it's easier. But of what you notice is that it is less accurate when compared to the sliding scale. Now, if it's emergency surgery, this is more challenging. There's poor plasma glucose control, there's sepsis, you need an endo review, and you need to optimize this patient before surgery. Then insulin therapy and regular plasma glucose monitoring. And you treat acidosis, dehydration, electrolytes imbalance before surgery. Plasma glucose of greater than 270 milligram per DL may be accepted if there is ongoing treatment. Now, anesthesia techniques and DM, we need to note that the signs of hypoglycemia are masked. So we will tolerate higher values than low values of glucose intraoperatively. And also during general anesthesia, you have to remember that general anesthesia masks major cerebral complications, so you need to be very vigilant. Then during regional anesthesia, there's reduced stress response, but we need to note that the patients can have autonomic dysfunction and and they can come down with profound hypotension as a result of that when you give them central neuroaxial blocks. Then you want to avoid epinephrine in peripheral nerve blocks. You want to do a low dose brachial plexus or intercostal blocks. You can use a low dose of epinephrine in those blocks. Then you have to note and document any prior nerve damage so that there's no issue of litigation after you put a block in a diabetic patient. Now, for our gestational diabetics, it's important to also know that autonomic dysfunction can now have a more profound effect because they can also have aortic cover compression. Then in patients, you have to be very careful not to be overzealous about your rehydration because they are prone to develop pulmonary edema because of their osmotic, colloid osmotic, reduce colloid osmotic. Sorry. Now, in conclusion, diabetes mellitus is a multisystemic disease. It's challenging. The preoperative management is challenging, but multidisciplinary approach improves the outcomes, surgical outcomes. A detailed pre-op assessment to guide our optimization is essential. Then good pre-op glycemic control, management of comorbidities and acute complications result in reduced risk perioperative and better surgical outcomes. Those are my references. Thank you for listening. Now, these are just questions that we can go through when we're done. All these slides will be sent to our various e-boxes. Thank you very much for listening.
Yes, thank you, Dr. Aderonke. How I wish I have the power to tell you to go on and on and on. It's been a bucket full of guidelines given to us to choose from in order to optimize our patients prior to surgery. The time is fast spent. We've indicated a lot of questions there in the chat room, and I hope you just take note of them because we're going to the second presentation. Afterwards, we'll come to the question. It's going to last 20 minutes each. So, Dr. Rotimi Olumuyiwa, are you there for us, sir? Hello, Dr. Rotimi, are you there for us?
Yes, sir.
Yeah, thank you so much. You are on. Please welcome Dr. Rotimi. He's a consultant anesthetic, and he's going to be taking us on the second very important topic. This is the new normal now. We're in an era of infectious milieu. So guidelines for anesthetic management of patients with infectious disease. That's what he's going to take us on now. So please, Rotimi, over to you. We've got 40 minutes so that we can wrap it up by 5 on the dot. Thank you.
Yeah, thank you very much. I want to thank the executive members of NSA for this opportunity and also to commend their effort. Well done. Good day, everyone. This evening, we'll be talking about guidelines for anesthetic management in patients with infectious diseases. By way of introduction, infectious diseases are disorders caused by pathogens such as bacteria, viruses, parasites, or even fungi. And they can spread either directly or indirectly, in which they are vector-borne, and they can move from one individual to another. So the clinical presentation is a function of the immune status of the host. So if the immune status of the host is fully functional, the disease symptoms may not develop. However, when you see patients come down with these diseases, it could be a function that it could be because the immune system is compromised. So you have two people exposed to the same infectious agent, and one person comes down and another person is unaffected. So there are some factors that are implicated, and we'll talk about this later. So healthcare institutions have a responsibility to implement changes to reduce healthcare-associated infections. Each institution is expected to have its own local guideline and to take responsibility for the staff in the workplace. Because we see at times when healthcare workers come down with infectious diseases, and we see some patients too that ab initio they are not positive for some infectious diseases, and along the line, while on admission, they contract this infectious disease. So there should be protocols, there should be guidelines that must be put in place, and there should be strict adherence to these guidelines, because it's one thing to have guidelines, it's another thing to abide with the guidelines. So each institution is expected to take responsibility as regards these guidelines and to ensure that it's being implemented. And also there should be a place for auditing. So the Health Act of 2006 provided the Healthcare Commission with statutory powers to enforce compliance with the Code of Practice for Prevention and Control of Healthcare-associated infection. So there is need for framework to plan. So there is need for planning, and there is also need to develop structures. And not only that, there is need to implement these structures and systems that have been designed so as to prevent healthcare-associated infections. What do we mean by guidelines? A guideline, by way of definition, is a statement by which to determine a course of action. So it could be a general rule, could be a principle, could be standard operating protocols or procedures, could be a form of regulation, or even a piece of advice. So a guideline is usually necessary for a system to work, because without guidelines, you have the control may not be there, and you have many healthcare workers or people working in a particular place will fall victims. So this can be issued by or used by any organization to make actions more predictable and presumably of higher quality. So if you want to improve on our quality of care as healthcare workers, there is need for us to have guidelines in every aspect of our practice. A major cause of healthcare-associated infection is the lack of consistent compliance by healthcare workers with basic prevention techniques, such as hand hygiene. It's unfortunate that we healthcare workers, at times we are the culprit of these things. We don't tend to obey simple instructions. Even during this pandemic, when it's being emphasized that you need to wear your face mask, you see some doctors, some healthcare workers, even within the hospital community, not wearing face mask. And you just wondered, what else, how else do these people want this message passed across? So it's very, very important. We should lead by examples. We should comply with any guideline or principle or rule that is laid down. Just, for the sake of, not only for the sake of the patient, but most importantly for our own sake too. Anesthetists should be in the forefront of ensuring that their patients are cared for in the safest possible environment. So the responsibility is on us as anesthetists, especially when patients come for surgery. We as team leaders, we need to ensure that everything is done in the right way, so that there will not be transfer of infection from patients to workers, or from even workers to co-worker. So there is need to ensure compliance. And also, as a team lead, we have the technicians working with us, and in some centers we have the nurse anesthetist, and also we have the scrub nurse in the theater, the surgeon. So we need to take charge and ensure compliance at all times. When there is deviance to lay down principles, we need to ensure that these are strictly adhered to, and we too, we should not be the faulter. So we're talking about guidelines for anesthetic management of infectious diseases. Actually, time will not permit us to touch all the infectious diseases, but I just like to bring out the common ones. So, of course, coronavirus, which is the current pandemic at the moment. Coronaviruses are a large family of viruses found in both animals and humans. So severe diseases such as Middle East Respiratory Syndrome, MERS, we have severe acute respiratory syndrome, SARS, and the novel coronavirus. So it's a group of viruses, and the symptoms start from mild cough, cold, to the severe form, which could be life-threatening. We have Ebola too, is a deadly and highly infectious disease caused by infection with a virus that can cause illness in humans and other primates. Influenza flu is a highly contagious viral infection too, which affects the nose, the throat, and lungs. Other ones, hepatitis. Hepatitis 2 is an infectious disease. It is an inflammation of the liver. The most common types are hepatitis A, B, and C. We should be very careful too with hepatitis too, because it is a deadly disease. We have HIV/AIDS, acquired immunodeficiency syndrome. It's a chronic, potentially life-threatening condition caused by human immunodeficiency virus. So we have other infectious diseases too, but time will not permit us. I just like to bring out the common ones. So the causes could be bacteria, caused by viruses, caused by fungi, and could be by parasites. Symptoms, each infectious disease has its own specific signs and symptoms. So during our pre-op anesthetic review, we need to review or assess these patients accordingly. So if you have a background information of the clinical state of the patient, so our questions will be geared towards that. And if not, we need to just we need to make to ask the questions generally. So, and the usual symptoms include fever, malaise, diarrhea, fatigue, muscle aches, and cough, among others. So depending on the organism and the type of infectious disease, and also depending on the clinical state. At what clinical state are you seeing this patient? It could be the patient may have some mild symptoms, may have moderate, and may have severe symptoms. Like, for example, COVID-19, we've done some cases that they were just mild. They had mild cases of pregnant women going for cesarean section. They had mild symptoms, and the PCR was positive. So, and also we had some cases that they presented with severe symptoms. Just imagine a patient that is a non-asthmatic and now having severe COVID-19. So is a big one. So for such patients, you need to assess the patient well, and also you need to observe the necessary protocol. These infectious diseases, how are they transmitted? Could be by direct contact or indirect contact. This is very, very important so as to assist us in prevention. Because if you have an understanding of the mode of transmission, that will help us to prevent it so that we not fall victim. So it could be transmitted from person to person. You have carriers, they don't have symptoms, but they are carriers. They're just going about donating these agents unknowingly to them and to the other people. So those donated or the recipients, depending on their immune status, may now come down with terrible symptoms. So one has to be very, very careful and practice universal precautions and prevention all the time. So direct contact could be by touch, could be through cough, sneezing, and for sexually transmitted diseases, could be through sexual contact. So for cough, so when the person coughs or sneezes, it's the virus goes into the air and they form droplets, and some they are in is airborne. And if the next person to this carrier person is not protected, there is that tendency the person gets the virus and within days becomes symptomatic depending on the level of immune status. Also, we could have animal to person, which have bites, scratch, handling of animal waste. To this could be hazardous. For some infectious disease, could be from mother to unborn child, either through the placenta, through breast milk, or through delivery at birth. We could also have indirect contact. Many germs may linger on an inanimate object. This is very, very pertinent for us as anesthetists, because some formats may be on our workstation, the anesthetic machine, on the tables, and anywhere, even the doorknobs. Some people, they go about with hand gloves, the same hand glove they use to touch patients, they use to intubate, they go to open doors, and they still go back to the patient, they hold the laryngoscope with it, they hold all sorts before they eventually now discard. With the same hand glove, they hold the pen, do chatting, do documentation. This is really not acceptable. So after, we need to have this sense of infection prevention control measures, and always adhere to it. And also we should show examples to our colleagues and also to our subordinates. Risk factors. There's some patients that come down with this infectious disease, and the risk factors include those on steroids and also some medications that suppress the immune system, like those that had transplanted organs, transplanted kidneys, and they're on some immunosuppressant agents. So they may come down with these infectious diseases. And also patients that are already compromised, like maybe with HIV, AIDS, they may have some superimposed infections too. And also they may have another superimposed infectious disease. Cancer or other disorders that affect immune system, those with implanted medical devices, those with malnutrition, extreme of ages, and also comorbidities. Patients with comorbidities, especially diabetes, they come down faster with these infectious diseases, and also patients with chronic kidney disease. Prevention, this is general prevention, and hygiene, and hygiene, and hygiene. This cannot be overemphasized. Is the singular and the most simplest way of ensuring prevention of these infectious diseases. Then also universal precautions, maybe in patients that have maybe HIV or hepatitis, you need to observe the universal precautions. Then social distancing for patients, infectious diseases that are airborne. Then when you are ill, you stay at home. But the reality of this when you are short-staffed is really a challenge. But the best thing when you are ill, actually, it's better to stay home than to come to work and now disseminate or share these viruses unknowingly. Then don't share personal items, travel wisely, make inquiries on vaccination. Then vaccination too can drastically reduce chance of contracting many of these diseases. Standard precautions. Anesthetists are sometimes involved in the care of patients who may harbor potentially pathogenic organisms not obvious. So we could have patients coming in for cesarean section, or patients coming in for angiography, ASA1 patient, similarly LD patient, and you may just think that, oh, this patient is LD, and decided not to observe the precautions. This is not right, because patient that looks LD may actually be harboring some dangerous agents. So there is need to observe standard precautions at all times. So this patient may harbor pathogenic organisms. I've seen a patient that was supposed to come for CS, and they just decided to do the PCR. It was an elective case in private hospital. They decided to go for, do elective CS, and they decided to do the PCR, and lo and behold, it came out positive. So they had to refer to our institution and was managed as a case of COVID-19. And so we just continued that way. So I was just like, this, we could most likely will have done some cases like that unknowingly. And since it's CS, okay, we are not, we are unlikely to do any instrumentation of the airway. And some other patients, so maybe they just come for day case anesthesia and so on. So there's need for us to be absolutely cautious and to observe standard precautions at all times for all patients. Precautions aimed at preventing transmission of organisms between patient and anesthetist or between patients must be a routine part of anesthetic practice. So transmission could be from patient to anesthetist, or it could even be from anesthetist to patient. We've seen some patients that they come in for elective cases, and some days after, the patient was not doing well post-op, and they were wondering what has happened. This is unusual, and decided to do COVID test, and it came out positive. So now lies the question: did the patient come in ab initio with this infection, or did the patient contract this infection in the theater suite or from the healthcare worker, or did the patient contract this infection while on the ward from other patients or from the caregivers? So one has to be very, very careful and ensure precautionary measures are taken at all times to prevent this transmission of infection to patient to anesthetist, anesthetist to patient, or patient to patient. Because, for example, if you use laryngoscope in one patient that is infected and is not properly cleaned, and use the same laryngoscope in another patient, then there's bound to be problems. So the Association of Anesthesia of Great Britain and Ireland recommends the use of standard precautions, which incorporate additional safeguards for specific procedures and patients. This includes single-use gloves, the use of fluid-resistant masks with a transparent face shield and gown. So there are many recommendations. Actually, there are many recommendations for each aspect of anesthesia delivery. So, but because of the time, this is just an overview and a summary. Precautions are recommended for all patients, regardless of their diagnosis or presumed infectious status, and must be implemented when there is a possibility of contact with blood. So there should be, when there is contact with the blood, there must be the minimum precaution that must be taken. When there is contact with all other body fluids, there must be the minimum precaution. Non-intact skin, mucous membrane. So all these things should be strictly adhered to. Preventive measures should be based on the likelihood of an infectious agent being present, the nature of agent, and possibility of dispersion. That's just flashing. So these precautions and hygiene. like I said, hand hygiene cannot be overemphasized. So it's very, very important. Then also the issue of the use of personal protective equipment. So when we approach the patient that have infectious disease, we should not compromise. The standard and the bar should not be let down at any time. If things are not available, let's ensure and take our stand as anesthetists. If we need to get across to the management or the people in charge, there should not be any compromise. There should not be any breach. So the personal protective equipment should be available when these patients are to be attended to. And these include the face mask for COVID-19 patients. Want to make use of your N95. Then you have your face shield or the goggles. You have your apron or the hazmat suit, and other things that are necessary. Then respiratory hygiene too is very important. If you need to cough, you need to show some etiquette while doing that. You need to cough into the cough side of your elbow. So, and also if you need to use tissue, the tissue should be used and discarded appropriately. So, and so also for safe, there should be safe injection practices, especially those that are transmitted through the blood. So safe injection practices should be abided by. So equipment and environmental cleaning, disinfection, and sterilization. We'll talk about this later. So for patients going for surgery, so there are some things that must be put in place. So the pre-op assessment, like I said, you take history, do your physical examination, and the relevant investigations will be ordered for, and you optimize your patient. So, and when patients come in, general traffic in and out of the operating theater should be kept to a minimum to reduce airborne contamination as much as possible. If the case is not that complex, there is no need for the operating theater to be bombarded with people that they don't really have any relevance to that surgery at that particular point in time. So one needs to ensure that traffic is minimum. Doors should be kept closed to ensure the efficiency of the ventilation system. Moving patients on their beds into the operating theater may increase the bacterial count on the floor. So all used linen must be handled safely to minimize the risk of contamination of the environment and staff. So there is need to ensure those that are in charge of this, that this should be observed. Used bed linen must be handled with care to reduce the release of small formite particles in the air. The use of separate trolleys from ward to transfer area and transfer area to table has not been shown to have benefit, although this practice continues in many operating theaters. So we see trolleys being brought from the ward, and so they transfer the patient from the trolley to the to another trolley in the theater and so on. So it's not really, from what is said, that is a common practice, but it has not been shown to have any benefit. Visitors, if they need to come in, should change into theater suites, wear designated footwear. So for the list, printed theater list should be available prior to the scheduled date. Dirty cases, as in patients likely to disperse microbes of particular risk to other patients, should be identified before surgery and the theater staff should be notified. So when this is done, it's really unethical to have a patient that has infectious disease coming for surgery, and the other team members are not aware. Yeah, it's the only surgeon that is aware, or is the surgeon and the anesthetist, the nurses are not aware, or technicians are not aware, or the surgeon and the nurse, they are aware, but the anesthetist is not aware. So is when such patients are coming to surgery, should be communication so that adequate preparation can be made. Like in the anesthesia side now, we need to ensure that the breathing circuit you are going to use is the one that after use you want to discard, or you may want to use some filter on the breathing circuit. And also you may have dedicated equipment for some infectious diseases. And also you don't want to use the usual equipment on the floor that is very, very valuable for such a patient. It's better to just have another set of equipment in which you can discard at the end, or if you want to make sure you clean or sterilize at the end of the day. So this is very, very important. Communication among team members is important. So where this is not possible, it's advised that a plenum ventilated operating theater should be available, and this requires a minimum of 15 minutes before proceeding to the next case after a dirty case. So this type of operating theater, it tends to filter particles more than like 5 microns, more than or equal to 5 microns. So it tends to filter it and allow it to be removed. So, but if it's not available, one can just wait for 15 minutes in such environment before you take another case. Then HEPA filters, which is high efficiency particulate care filters, if available too, they are very, very important. They are very, very good. It helps to remove particles, can remove very, very or smaller particles greater than or equal to 0.3 microns. So it's very, very important, and is good for the theater environment. The most probable routes of transmission of infection between successful patients are airborne or on items and services that are being in contact with the patient. So it could be airborne or surfaces. Appropriate cleaning of the operating theaters between all patients should be undertaken. Whenever there is visible contamination with blood or other body materials, the area must be disinfected. So we use sodium hypochlorite. You can have your own protocol. Ideally, each institution or each hospital should have a local protocol guidelines that guides what they are doing. If not, everybody will do everything anyhow. There will not be standard. Somebody will come, will do one thing today, another person will come, will do another thing. So, and it causes confusion. And also the residents or the upcoming anesthetists will be at a loss that what are we actually doing? So, and the person unfortunately may now take the wrong method. So there is need for protocol to be developed for every aspect. A protocol for intubation, protocol for taking care of patients, protocol for regional. So different guidelines should be instituted, and also for invasive procedures too. So different guidelines should be instituted for each unit and in each institution, and this should be adhered to. Floors of the operating room should be disinfected at the end of each session. So disposal of shafts, accidental injury, which is major operational hazard in the healthcare setting, is something of concern. So there should be safe use and disposal of sharps. Accidental inoculation with infected blood, however small in amount, present a significant risk to anesthetists. Study done in UK found out that 16% of occupational injuries occurring in hospitals, they are attributed to sharps injury. So, and these predominantly are caused by needles. And these are occurred during venipuncture or when intravenous drugs are being administered or when there's recapping of needles. So the guideline says when you should not recap needles, but people still recap needles. You should not. This should be preventable by adhering to national guidelines and agreed standards. Some have had needle pricks in patients with known HIV, and they've had to go for post-exposure prophylaxis. So it's not a pleasant thing for those that had such an experience. So prevention is better than cure. Sharps must not be transferred between personnel and handling should be kept to minimum. Needles must not be bent or broken prior to use or disposal. Needles and syringes must not be disassembled by hand prior to disposal. Needles should not be recapped or reshifted. Used sharps must be discarded into an approved sharps container at the point of use. We see some healthcare workers too that after they are done with their sharps, they just discard it anyhow. This is not acceptable. They just discard into the general trash bin. Is not acceptable. The sharp bin should contain the sharp bin and also the broken ampoules. So because if the cleaners or those that that are involved with waste disposal, when they come in and they don't know, they just assume that somebody somewhere will have used the sense to discard this thing appropriately, and while trying to pack it, they may just have needle prick, and that will be unfortunate because of the lapse on the part of someone. So it's better to just observe all these things at all times. So use sharps and broken ampoules and every other thing that needs to be in that sharp bin should be there. Blunt aspiration needles should be used for drawing up drugs. Needle protection device may reduce needle stick injuries, but require further evaluation before widespread use can be advised. Preventing contamination of drugs. So drugs and fluids require safe handling by anesthetists, and local protocols for preparation should be followed. Syringes and needles are sterile, so single use should be done. A syringe must not be used for multiple patients, even if the needle is changed. Some they are in the habit of using syringes and just say, "Is needle that have changed?" So no, you should not use syringe for multiple patients. For the drugs, care must be taken when drawing up drugs. Single-use ampoules should be discarded after the required amount of drug is drawn up and not reused for subsequent patients. Ampoules must be kept for identification purposes and discarded at the end of the list. Multiple-use ampoules are not recommended. So before use, prepared syringes and needles should be stored in a clean container and syringes capped to avoid contamination. So at all times, you should make sure that syringes are capped. After use or at the end of anesthetic, all used syringes with needles should be discarded into an approved sharp bin. Talk about that. Then talk about infusions through. We need to ensure aseptic technique at all times. We need to. I see some people when they may start an invasive procedure in an aseptic manner, but before the end of the procedure, they've contaminated themselves. Or maybe while doing it, they needed assistance, and the assistant is not well scrubbed or not putting on, not wearing sterile gloves, and they just assist them, and before you know it, everywhere is contaminated. So we need, this thing should not be taken for granted, because at times you may not know the repercussion, because you have that short period or short encounter with the patient, and the process starts from that time. You may not even see the patient again. Is at post-op that people will start managing patients. There was one surgeon that told me that the patient came in for neurosurgery, and the the patient has the patient is now okay, but they are managing the wound caused by the arterial cannulation. I was like, why? Where was that done? So what happened was they tried there was several attempts at arterial cannulation. So, and at a point they lost the asepsis. So they were just trying to get the outline, several trials, and at the end of the day, they got it. But what happened? Days after, the patient developed a very big wound on that radial area, on that forearm. So asepsis technique should be adhered to at all times. So injection port should be maintained with a sterile technique. It should be kept free of blood and covered with a cap when not in use. Connections and injection ports in IV line should be kept to a minimum. Then needle-free lower injection device should be used to cover exposed female lower injection ports, because it could serve as a source of infection. So we need to do that. So there are some decontamination processes. We have cleaning, in which you can remove foreign material from an item. We have what we call low-level disinfection, high-level disinfection, and sterilization. So low-level disinfection kills most vegetative bacteria. High-level disinfection kills vegetative bacteria, not all endospores. So the low-level we kill most vegetative bacteria, and you can use disinfectant like sodium hypochlorite or 70% alcohol and fluoxetine. While high level can make use of peracetic acid, aldehydes, chlorine dioxide. Then we have the highest level of decontamination, that's the sterilization. The process used to render an object free from viable microorganisms, including all bacteria, spores, fungi, viruses, and with techniques such as autoclaving. We have risk assessment. So choice of equipment and level of cleanliness required of reusable items will be assessed against the risk posed to patients of transmission of infection during any procedure in which you have to make use of equipment. So the Microbiology Advisory Committee came up with these three levels: the high risk, the intermediate risk, and low risk. So since, we make use of devices, so there are some with high risk, some intermediate, and some with low risk. So there should be infection control policy, and these include different, because as anesthetists, we make use of equipment. We make use of many equipment. So there's need for us to know how to handle these equipment so that there would not be transmission of infection from patient to patient. Anesthetic face mask is usually contaminated by secretion. So, and this is implicated in causing cross-infection. Just imagine you have a patient that's infected, you use a face mask, and then you are trying to assist ventilation, and there's secretions there. Patient decides to bring out some secretion, and it's not properly cleaned, and you have another patient come in, and you put the same face mask on another patient. That would be disastrous. So there is need to ensure that anesthetic face mask should be properly cleaned, and ideally it should be single use or should be sterilized between patients. The airways and the tubes are oropharyngeal airways, nasal airways, ventricular tubes are readily become contaminated with transmissible organisms and blood and should be single use. Ideally should be single use, but in some centers, oropharyngeal airways are multiple use. So reusable supraglottic airway should be sterilized not more than the manufacturer's recommendation, like the LMA now. So there's recommendation for sterilization of laryngeal mask airway should not exceed particular number. If not, you will not be able to, you won't guarantee, you'll not be able to guarantee the efficiency of that device to be so floppy, and it will not do the work that is intended. So catheter mounts and angle piece ideally should be single patient use. Anesthetic breathing circuit, use of filters is recommended and disposed of after 7 days. You change if it's visibly contaminated or used for highly infectious cases. So our anesthetic breathing circuit should be used. Actually, it's better to use filter rather than just use HME. So it's better to do that. And if it's soiled, we discard it. The machines, anesthetic machines, manufacturers' cleaning and maintenance policies should be followed. Surfaces should be cleaned routinely, daily sterilization and disinfection. The laryngoscope should be decontaminated. Bougies, fiber optic bronchoscope, because it's expensive, cannot be autoclaved, so you decontaminate it. So way forward, there should be collaboration with infectious disease unit specialists to ensure standards and monitoring. So there is need to collaborate with these people. Precautions against transmission of infection between patient and anesthetist or between patients should be enforced. The culture of hand hygiene should be imbibed among anesthetists. There should be compliance with local theater infection control policies. Decontamination practices for equipment should be followed and audited so as to assess your level of compliance. Single-use equipment should be utilized where appropriate. New viral bacterial filter for breathing circuit should be used for every patient. The local policy for use of breathing circuit should be developed. Appropriate infection control precautions must be taken during procedures in high-risk patients. Invasive procedures like central line or spinal or epidural. So you need to ensure that microbiology should be designated to provide advice on microbiological aspects of the contamination and sterilization. So as a round-off, we are in the era of COVID-19, and there is need to observe guidelines for patients. I'm sure in all our centers, we've had patients with COVID-19, either directly or indirectly. Somehow they must have come in. So, and if these patients are to go for surgery, what should be done? The strict infection prevention control should be observed. And also there should be a multidisciplinary approach to it. And there's need to have drills. There's need to have drills so that you know the safe zone, you know where you done, where you dug, and this should be guided or supervised by an infectious disease personnel or the hygienist or body, as it were. And also protocols should be made at different centers on how to manage this patient. Intraoperatively, use of video laryngoscope, intraoperatively is advised, and also fast-acting agents, use of succinylcholine, and so on. So there are so many protocols, and we need to just ensure these are done, and also you avoid aerosol generating procedures as much as possible. So in conclusion, a major cause of healthcare-associated infection is the lack of consistent compliance by healthcare workers with basic infection prevention standard of care. Anesthetists should be in the forefront of ensuring that their patients are cared for in the safest possible environment. Development and strict adherence to guidelines for anesthetic management of infectious disease is crucial to prevent transmissions of these infectious diseases from patient to healthcare workers, or patient to patient, or healthcare workers to healthcare workers. Thank you.
Well, thank you, Dr. Rotimi. We're so grateful for the great presentation. We want Dr. Aderonke to take up the questions on the chat now. It's going to last for 10 minutes. Questions that cannot be answered within, the answers will be supplied much later so that we can keep to time. There is somebody signal you want to say something. I think Dr. Gabriel, if I'm correct, can see this clearly. Please, can you put your question in the chat there because of the limited time we have? Dr. Aderonke, are you there for us?
Yes, I'm here. Can you hear me?
All right. Yeah, you can go ahead with the questions.
Can you hear me? Okay,
Yes.
good. So the first question I'm going to answer is about how do you make a diagnosis or assess the patient for autonomic dysfunction when you go for a preoperative assessment. Now, the autonomic system consists of both the parasympathetic and the sympathetic. So for the sympathetic nervous system, you want to check the patient's systolic and diastolic blood pressure and note the changes from when the patient stands up from lying. So you take the blood pressure while the patient is lying down and when the patient stands up. With the patient standing. Now, the blood pressure, diastolic blood pressure should change by at least 16 millimeters of mercury if the patient doesn't have autonomic dysfunction. But if there's autonomic dysfunction, the diastolic blood pressure reduces by less than 10 millimeters of mercury when they are standing compared to when they are lying down. Then the systolic blood pressure also in a normal patient should the change from lying down to standing position should be less than 10 millimeters of mercury. But in patients with autonomic dysfunction, it is greater than 30 millimeters of mercury. Now, for the parasympathetic, you want to measure the heart rate. Your heart rate in a normal patient, there should be increased by at least 15 beats per minute when they are breathing. But with patients with autonomic dysfunction, the increase in heart rate is less than or equal to 10 beats per minute. Now, for the question on glucagon, normally your liver breaks down alcohol when you drink it. So when a patient has hypoglycemia, ideally the glucagon given should signal to the liver. The liver should receive signals that will cause production of more glucose. But because of the alcohol in the system of the patient, the liver just ignores the signals by the glucagon and continues to break down the alcohol, rendering the glucagon useless. So this is not acceptable or useful in patients that are drunk. Now, the other question also was the sugar level that I spoke of between 6 to 10 millimole is perioperative. And it's a guide for the perioperative period. So it's not really like, oh, if it's not between that to that pre-operatively, you will not take the case. It's a guide for you for the perioperative period. So when you're going to be monitoring the patient all through the perioperative period, you want to maintain it within 6 to 10 millimoles of fasting or random blood sugar. Now, the conditions that should be met for uncontrolled blood sugar in emergency cases. The conditions that should be met include you must treat acidosis, you must treat dehydration and electrolytes imbalance before the patient is anesthetized. The high blood sugar can be controlled. Continuous or an ongoing treatment of hypoglycemia can be done. So for emergency cases, it has been said that even values up to 270 milligram per DL can be taken as long as all these other factors are controlled and treated before you put the patient under anesthesia. Thank you.
Thank you so much for that crystal clear response to questions. I'm sure a lot more questions will be coming up. We'll find a way to get the answers across. This presentation is being recorded, so you can rest assured that the ESCO and the IT team are doing everything to get to you up-to-date responses to your questions. Due to time limit, we may not be able to answer all questions here. Dr. Rotimi, are you ready for us?
Yes, sir.
Yes. Can you go ahead with the questions meant for you?
The questions section. Okay, so I'll just try and read out the ones I have here. There are some comments too.
Okay.
There's a comment: some institutions count the number of gloves per case. Hence, doctors are reluctant to discard when not soiled. Hospital policies must be reviewed to provide adequate quantity of PPE. Yes, absolutely. We need to, there is need for advocacy, and hospital management should be involved, and we need to communicate to them the need for these things to be provided. So, because if it's not provided, we are doing more harm than good. So we need to just have communication with hospital management. So the other question said, patients without any immune system, patient without any immune system, that is no comorbidity compromise, can they present with severe form of COVID-19? Yes, patients without any problem with the immune system, they can present with it because it's multifactorial. Actually, it's multifactorial, and they may not have comorbidity, but they may have some other issues. And also, it depends on the strain of the virus. It depends also on the amount or the extent of the inoculation of the virus. So there are many things that may predispose to this. And also, if at that time, if the person is down, may not really have comorbidity, but maybe the patient has malaria at that time, or has some upper respiratory tract infection, or is even stressed. So it's not necessarily that it's the comorbidity, but there's other confounding factors that may be responsible for the presentation. So any patient can come down with a severe form. And we should also remember that this is a novel virus. We really don't understand the dynamics fully of the pathophysiology or the cause of this virus. So anything can happen. Can dexamethasone be used in the treatment of COVID-19? Definitely yes. Dexamethasone is being used for the treatment of COVID-19. However, for dexamethasone, there is a particular dose in which you should not exceed, because it's been found that if you exceed that dose, it doesn't really confer any additional advantage. And at the same time, too, patient must be on supplemental oxygen when patient is being put on dexamethasone. The other question says, doctors don't take precautions. Okay, I think this is a comment. Doctors don't take precautions when interacting with their colleagues, but do so when attending to patients. It should be at all times. Reports exist of infection transmission from one health worker to another. Absolutely, I absolutely agree with this comment. So we see our colleagues as somebody that cannot transmit, or somebody that is safe. So everybody should be seen as a suspect until otherwise proven. So just assume your next door neighbor or your colleague at place of work has infectious disease. You're not praying that the person has it, but just take precaution, because you don't know, out of 10, one may have it. And if you are now exposed to that, and you don't know your level of the immune status, the person may come down with life-threatening presentation. So this comment is very crucial. it's not only with patients, but our colleagues too should try and observe these protocols. Says, thank you, our teachers, for these educative lectures. Can we get a copy of the presentation, including last week on? I'm sure the executive members will do that. In COVID-19, where is the position of the filter with respect of the breathing circuit and anesthesia machine? So the filter is, you put the filter both at the patient end and the anesthesia end. So it's advisable to put the filter at both ends. Will there be a time when unvaccinated health workers will not be allowed to work? I can't answer that one. So let's see how it goes. The next lectures, okay, this is just a comment. What is the role of pre-work placement health screening? What is the role of pre-work placement health screening? Well, it's very important. In some centers, in some companies, you need to go for health screening before employment. And even if they notice that you travel for a long time, when you are resuming back to work, you need to go and do screening. So the role, well, it can help to identify the people that have this infectious disease that may be asymptomatic or that are carriers, so that such a person will not affect co-workers and will not have a big case in their hands. Okay. So why do you say patient must be on oxygen when taking dexamethasone? Well, it's part of protocol. Do you mean that is hypoxic patient we use DEXA for? Well, it's advisable to, no, not really hypoxic patient. You know, well, there are different levels of hypoxia. So, but when dexamethasone is given for COVID patient, especially, it's advisable to put on supplemental oxygen. Then high doses, you said high doses of DEXA are being used up to 18.9 milligram. Well, different centers with their different protocols. Different centers with different protocols and also the doses. So, but it's been found out that even if you have high doses, it doesn't really confer the added advantage. And also, you know, these steroids, when you give high doses, it tends to cause some other unwanted effects, side effects, which are not desirable. So one has to be cautious in using dexamethasone, even apart from the fact that it has this anti-inflammatory response, effect. So yeah, I think that's all. Thank you very much.
Well, thank you so much, Dr. Rotimi, for clarifying some of those issues surrounding the questions. And we want to thank all the presenters, over 150 participants, despite the challenges of network. And want to thank the IT team and the EXCO. Please do remember that the finance team fund this. They are paying for this, and we should look at our forum for the account number for NSA and promptly pay our dues, because very wonderful presentations are in the pipeline, and we really need funds to make them happen. There are people working behind the scene. We want to thank those that promptly pay their dues. Before we go, we want to welcome the president. She's been in the background, putting up a lot of information. I want to thank her so much. Prof, you're welcome.
Hello, good evening. Thank you very much for beautiful moderation. We want to thank our speakers for the erudite presentations. Dr. Ronke Adesina, immediate past secretary, and Dr. Rotimi. Thank you very much for the interesting lectures. We appreciate you. I want to use this opportunity to remind us that the next lecture series will be next Saturday, same time, same station, and we'll be listening to Dr. B.B. Oshinaike, the Vice President of Crystal Care Society of Nigeria, and Dr. Irene Akideno. She'll be talking on factors affecting inhalation and anesthetic agents. So please join us, make it a date with us, and yes, remember to pay your dues. Thank you very much. See you next time. God bless. Bye. Over to you, Dr. Mohamed Sani.
Thank you so much. Social event going on. So thank you so much, everybody, for coming on, and we hope to see you next week. We pray the network could be so beautiful and seamless so that much more beautiful package come your way. So till then, please keep safe and take all precautions. You've heard today.
Bye. Please, before you go, let's do our photo shoot. Don't forget, everybody. Let's do our photo shoot. Before you go, put on your cameras. Let's do our photo shoot. Dr. SDK, you are there. Hello, Dr. SDK. You are in theater. Dr. Adesina.
Good afternoon,
Can we put
ma.
on our videos? Afternoon. Sorry, I'm at a wedding, but I have to multitask now. Put on your videos that we can do. Let's do our photo shoot. Take the pages on which you appear and put them on the platform so that everybody will join us next week. You can take the page, you can screenshot the page you appear and put it up. Dr. Elumelu, thank you. We had many participants. We had many participants today. Almost
Dr.
at a point,
Becky,
170 participants. Please, let's make it better next time. We have a limit of 150, so we can take as much. Of 500, sorry. Hello, Dr. Rod, so that we take a screenshot. Our honorable speaker, thank you. Give us a smile. Nkechi, give us a smile.
Afternoon, ma. Thank you, ma.
Afternoon. We want to see your smile, your beautiful smile. Well done. This was a very, very well arranged program. Well done. Kudos. Kudos to you and the IT team.
Thank you, ma.
Thank you very much.
Thank you very much,
Akomu, I dey see you. Oga Akomu, I dey see you.
My president.
Dr. Akomu, I'm with you.
My president. Thank you.
Dr. Akamu, we are waiting for you to take some lectures, so you have to take the next set of lectures. Dr. Aliyu, well done. Seeing all of you. Dr. Adeoye, well done. Dr. Beckley, where is your camera? Dr. Onyeka, we want you people to take lectures during the next series. Please, Dr. Akamu, Dr. Beckley, all of you.